and tolerability. The other two important things are the quality of the life. That is, if we are giving a drug, whether it improves the quality of life. For example, the patient with dyspnea, the patient has chronic obstructive pulmonary disease, and the patient cannot walk just 5 meters or 10 meters without having some breathlessness. So, if we can improve the breathlessness, that will ultimately improve their quality of the life. And for improving this quality of life, improving the efficacy of the drug, safety of the drug, controlling the disease or curing the disease also needs the adherence of the drug. Adherence of drug means the patient have to take the drug as prescribed by the physician. So, if a physician tells that you have to continue this drug for 3 months, twice daily, so the patient have to continue. But if the patient just continue this for 1 week or 2 weeks and then discontinue it, then the effect of the drug will not be pronounced. So this can happen due to some safety issues. That is, there will be some adverse effects of the drug. One thing, and another thing important is the economic issue. That is, the patient cannot buy the drug. The patient cannot obtain the drug within his or her socio-economic strata. So ultimately, here comes the important points of the pharmacology. So basically, when in a program, for example, we are buying a drug for the mass vaccination or the mass control of worm infestation. So there may be 3 drugs. So for this, we have to do some pharmacoeconomic evaluation. That is, we have to see the pros and cons of the efficacy, safety, as well as the economic portions of the drug, whether it can be cost effective or cost beneficial for that particular part of the population. So basically, pharmacoeconomic analysis, this is the definition. So it is the comparative analysis of alternative doses of action in terms of both their cost and consequences. That is, in the one hand there is cost and in the other hand there is consequence. So we are balancing both of them. So there are the outcomes. So outcomes may be medical outcome, that is, it may be some cure or the control of the disease, and there may be some surrogate marker. That is, if we are giving some anti-hypertensive drugs, we are decreasing the blood pressure, and basically this decreasing blood pressure is a surrogate marker for our cardiovascular health. So basically, we are decreasing the cardiovascular mortality also if we are continuing the drug for long-term benefit. So medical outcomes basically deals with eco model. Eco means clinical, humanistic, and economic. So we are mainly dealing with until now the clinical outcomes. That is, whether the drug is effective or not, whether the drug is safe or not. Apart from this, another important is the economic and the humanistic. Humanistic is the quality of life. Whether the drug is improving the quality of the life of that particular person, and whether it is the economic hurdle for the person to continue. So clinical outcomes, what I have discussed, either it is cure, comfort, or survival. So there may be, if this is an acute disease, for example, this is a bacterial infection, that will be cured by the drug. If there is a chronic disease, for example, diabetes mellitus or hypertension or cardiovascular disease, our motto is control the comfort and the survival. Ultimately, some drugs improve survival. There are some drugs. So this is the critical outcome, and this is the humanistic outcome, that is the quality of life only. So there may be improvement of the physical function, emotional function, social function, work performance, and there may be different types of the milder symptoms that may be hampering the daily routine of a patient, that can be controlled or that can be cured, and all these uplift the quality of life of the patient. And lastly, the economic ones. And the economic ones are basically expressed in terms of the cost or value of the delivering care. So there may be expense, savings, and cost avoidance. So all these are possible. So these are the examples of the different outcome measures. Very easy. For example, we are dealing with the disease of hypertension. So for the hypertension, quality of life. So quality of life. প্রথম যেটা dyspnea পেশেন্ট তার হাঁটতে পারছে না একদম, এবং তার শুধু আমরা ট্রিটমেন্ট করতে হবে না, 5 years of drug A in one group of patients and drug B in another group of patients. In 5 years, there may be 100 patients, there is also 100 patients. Now we are calculating what are the number of the strokes happens in these patients in drug A and drug B, and what are the expenses of the persons if they are continuing with the drug A or drug B. Now we are dividing this as cost plus product. This is in the simplistic term. So likewise we can calculate cost for lifestyle say or cost for decreased millimeter of mercury. So it is clear. So there may be different drugs. Drug A may be of costly and drug B may be of cheaper, but drug A decrease the mortality rate very high. If we compare with the drug B, and ultimately if we compare these two pharmacoeconomic terms, it can be seen that in spite of costly, the drug is pharmacoeconomically more advantageous than the drug A. It may happen. So basically we are evaluating pharmacoeconomically, not just only the cost. We are comparing this cost whether this is for the long term, how much it increases the blood pressure, how much the life years are saved, how much strokes are avoided, how much maternal infarctions are avoided. This is example of the hypertension. Similarly for hyperlipidemia or diabetes or asthma or for any chronic diseases or also acute diseases we can get. So basically what I am talking about is comparing the cost and consequences. So there may be A and B, there may be drugs or there may be program also. So for different types of the program we are using the different drugs, or for program perspective there is also cost. For example, we are doing some psychological counseling of depression patients. This may be a program. So we can see that whether the psychological counseling is may be given by two ways. Whether that is more costly, one thing that is maybe less costly, whether the depression incidences are lesser in one arm and another arm whether it is decreased. Similarly, we can compare these two. So program A, program B, or drug A, drug B, and consequences A and consequences. So we can evaluate all these. So you can see comparison of the two or more alternatives is there or not, and are both cost and consequences of the alternatives are examined or not. This is the example. The way. So if we are only examining the consequences, there will be this may be called as the outcome-based research. And if we examine only the cost, that is the cost-based research. Cost-based research means drug A cost is drug B cost is. Here we are not considering the consequences. Okay. So we are examining only cost. If we are examining only the consequences, only we are seeing irrespective of the value of the drug, whether that is decreasing any mortality or not. That is the outcome basis. So if we are balancing both the cost and consequences, this is one of the cost outcome basis. Here we are not comparing, but we are describing what are the cost and what are the consequences. Similarly, if we are comparing two drugs to see their efficacy and safety without coming to the economic perspective, that comes under the part of the clinical drug. So any drug that comes after any drug that comes in the market, they have to undergo the clinical trial. So in the clinical trials, we are mainly concerned with the efficacy and safety of the drug, but not the cost perspective. Cost analysis means we are just analyzing the cost of the two drugs, not two drugs. But when we are considering both the consequences of the two drugs, and we are analyzing both the cost and consequences of the two programs of drugs, that ultimately comes from the party of the full economic evaluation. That is, we are evaluating the full economic benefit, whether that is cost beneficial or cost effective or not. So this full economic evaluation can be done by four ways. These four are the terms. One is cost minimization, another is cost effectiveness, third is cost utility, and the fourth is cost benefit. So for cost minimization approach, we have to measure. One is cost and that is outcomes. These two are measured by different units. For example, cost is measured in dollars and outcomes is equivalent of that. For cost effectiveness, dollars and natural unit. Natural unit means, for example, in case of the hypertension, per millimeter mercury decrease of the blood pressure. For cost utility benefits, we have to compare the cost in dollars and outcomes in quality adjusted lifetime. Here comes the numerical output. That is whether that cost is equivalent or whether that program or that drug is more beneficial in improving the quality of life of the person. And cost benefit is basically they are compared both in case of the dollars. So outcomes is also changed into the dollars. That if we are increasing the blood pressure, such millimeter of mercury, ultimately that should be helpful in terms of the monetary benefit. For example, if we are increasing the blood pressure well below this one, that is well below 130, that will decrease the hospitalization of the patients, that will decrease the maternal consumption of the patients. That can be calculated by different types of the calculation of here. So that can be also expressed in monetary units. So in cost benefit analysis, both of these are expressed in monetary units. That is in the dollar. So first coming to the cost minimization analysis, examines on the cost of competing technologies. So competing technology or competing drugs, we are examining the cost as its equivalent effectiveness. Basically, these are done when already a drug is there and we are also coming out with some generic drugs. So you know, when a drug comes to the market, the drug has some patent period of that originator company. So after the patent period is over, the drug can be manufactured by different other companies also. These are one of the generic versions of the drug. Now we can compare the economic perspective of these branded drug and generic drugs also. And this can be done by the cost minimization factor. So when a first drug comes, that will be very much costly. The newer generic drugs, that may be lesser costly. So we can see whether the cost is very much minimized so that it can be very much effective or not. We can analyze this. Two or more drugs in the same therapeutic class with similar side effect profile. We can do this cost minimization analysis. We don't need details of the analysis of this. Just take about the concept and different names of this pharmacoeconomic analysis. Okay. So net result is basically expressed as cost per patient treated. So this is the cost and this is divided by number of the patients treated. So this is the example. So these are the different drugs. These are the diabetic drugs. So this is used for the diabetes. This is the cost per month. Glycuride. This is the originator drug and this is another generic drug. So two types of the glycuride from two companies, from three companies. Utilize another drug in the same class. Okay. All these are basically examined by means of cost per month. And then we can just see whether in which case the cost is minimized and this is expressed per patient. That is the total 100 number of the patients are basically economically evaluated and this is the cost, and if they are continuing with this drug, the total after the end of 1 year, what amount of the cost is used and what amount of the cost is used, and that is subtracting, and this is the cost minimization factor. This is the easier term. Next, coming to the cost effectiveness analysis. This is important, cost effectiveness. Here the cost are measured in physical units and value in monetary units. And effectiveness is measured in natural units of health input. That is the unit that is used in that particular scenario. Clinical outcome measures here are added like prevention of event disaster example. So basically outcomes are not to be measured in the same units compared interventions. Again for the diabetic drugs, you can say that in one drug A, these are the cost in after the 1 year in dollars. And what are the effects? The effects may be the prevention of the myocardial infarction. So we can see if we are using this antidiabetic drug after the end of the 1 year or 2 years, how many numbers of the stroke are prevented. So this may be a unit, and this can be compared between two or more drugs. But we can compare cost per reduction in HbA1c with cost per reduction in systolic blood pressure. That is, that if the unit is separate, we cannot compare it. So, if we are comparing this, both of these have to be the same unit. So, we cannot compare, we cannot do cost effective analysis between an anti-hypertensive drug and an anti-diabetic drug. So, anti-hypertensive drug unit is separate, anti-diabetic drug unit is separate. So, results are expressed as cost per effect. So, we can see, so this is $100 per 1% reduction in HbA1c. So, HbA1c we are seeing that this is the $100 per 1% reduction in HbA1c in one drug, like this. $50 per 10 milligram reduction in LDL, $5 per symptom-free day. So these are the examples, just to give you concept. So by this we can use the cost effective, and then we can compare the different drugs, different programs. So in one drug there will be $100 per 1% reduction in HbA1c. In another drug there will be $200 per 1% reduction in HbA1c. So the drug will be more cost effective than drug like this. But it does not mean that ultimately this is more efficacious or this is more safe. This is in terms of the economic evaluation. Just remember. And we can just express the incremental cost effectiveness ratio. That is drug A and drug B. What are the units? The same thing. So this is the total cost of the treatment for drug A, TC1, and this is the total cost for treatment for drug B, TC2. And we can divide this with the effectiveness 1 minus effectiveness 2. That is the increase. How many times the HbA1c is decreased? We can subtract this and we can come out with the incremental cost effectiveness ratio. So previously I have already discussed about the example. So you can see for the drug A, the total cost for 100 patients, for example, $10,000, and effectiveness is 10 strokes prevented. For example, after 1 year. And for drug B, total cost for 100 patients is approximately $60,000, and effectiveness, for example, 50 strokes are prevented. So, in spite of, you can see this is very cheap than this, but here the effectiveness is more. Now we can just calculate this, and ultimately we can come out with the cost effectiveness of this. So you can see 10,000 is 60,050. So cost stroke prevented, here it is $1,000, here it is $1,200. So at first glance, we can see that in spite of drug B is more costly, it decreases the stroke very effectively. But when we are analyzing this, we can see that drug A is more pharmacoeconomically superior than the drug. So this is simple mathematics. So at first glance, we can perceive one, but when we are evaluating this, the perception is very different. So incremental analysis is thing. So after the cost effectiveness analysis, next important thing is the cost benefit analysis. We have the resources from and get outcomes are measured in monetary units. Okay, so both are expressed in monetary units. So we have to choose the treatment with the highest net benefit. So basically, results are expressed in benefits minus cost, so net benefits. So what are the net benefits? I have already given example. So we are using again the drug A and drug B. For example, mortality is prevented. Mortality of hospitalization is prevented. So it will be calculated that if a patient is more hospitalized, what will be the hospitalization cost of that person. So this is expressed both in the monetary units. So the benefit is also expressed in monetary units, and the cost is also in the monetary units. And then these two are subtracted, and for this we can get the net benefit of that drug. And then the two drugs or three drugs can be compared to one another. So this is we have to accept the programs or set of drugs with net benefit or benefit by cost ratio greater than 1. This is simple. If the cost is more than benefit, we should not accept that. Benefit is to cost greater than 1 means benefit is more than the cost. So this may happen with some programs. There may be some mass vaccination camp. We can see the cost is more than the benefit. So ultimately it cannot survive for long term. For this cost beneficial approach is more important for some programs, that is the national programs or state programs for prevention and control of some diseases. For example, COVID vaccination. So before COVID vaccination, the government have done some cost beneficial analysis also. So which drugs should we give? There will be different types of the vaccines like COVID, vaccine, and Sputnik, etc. They have decided, different countries also decided that if we are giving this to such number of persons, whether it will be cost beneficial or not, because we need to continue this for long term. If the cost is more than the benefit in terms of units, the program cannot survive for long. So for benefits per cost is net benefits, net cost, the same thing. So this is the difference between the cost effectiveness approach and cost benefit approach. two are the main important. Just remember this. Cost effectiveness approach. Cost is expressed in monetary units, and effectiveness is expressed in natural units of that disease. Okay. For example, for hypertension, dollar per decrease of millimeter of mercury. In cost benefit approach, both are expressed in monetary units. That is dollar per dollar. That is, if the patient is hospitalized or if the patient becomes ill, what will be the monetary problems? This is also expressed by means of the mathematical. There are mathematical modeling, and with the help of this modeling, this is also expressed. So this is cost benefit approach. Lastly, coming to the cost utility analysis. So here the resources consumed measured in monetary units, and the health outcomes are measured in humanistic outcomes. So at the first, I have told that apart from the efficacy and safety of the drugs, the other two important things are the economic evaluation of the drug and the quality of the life evaluation of the drug. So if we are combining both of these economic perspective and the humanistic perspective, that comes under the party of the cost utility analysis. So here the quality adjusted life here is usually used as unit. It is based upon utility, that is the patient preferred. Okay. So utility is the value or what based on the level of health status or improvement in health status as measured by the prevalence of individuals or society. For example, if a patient has COPD, chronic obstructive pulmonary disease, and due to the dyspnea, the patient misses going to the ward per month approximately 2 or 3 days. So this can be calculated. The 2 or 3 days wages are lost for that person. So this can be calculated, and this can be extended by mathematical modeling. And for this we can calculate the quality adjusted life years. Now we are using one drug A and drug B. Whether the quality adjusted life years is more improved in one or in another, and then we can just analyze it. So this is comes under the cost utility analysis. So basically, this cost analysis framework is needed when we are creating some guidelines or we are creating some program. For example, now there is body like RSSDI for diabetes or American Diabetes Association, and we have, for example, 5 drugs in our hand. Okay, now the guideline committee have to decide which drugs should be used as the first line drug for diabetes. What will they do? They will see the different types of the clinical trials of these 5 drugs. They will see the meta-analysis of these 5 drugs, and they will also evaluate the economic evaluation whether these 5 drugs, what are the differences of the cost effectiveness and cost benefit of these 5 drugs, and accordingly they can promote among these 5 drugs one drug that this can be started as the first line. This is example. So for the guideline perspective or for the program perspective, this pharmacoeconomic evaluation is very important. So to conclude, pharmacoeconomic analysis is basically a valuable tool to answer a clinical question. Cost effectiveness, efficacy, safety, tolerability, cost, quality of the life, all are important. So not only the efficacy and safety, the other perspectives are also important in our modern usage of the drugs. But there will be others, there are limitations on the modeling, because for these evaluations we have to analyze the sensitivity also. So these are different types of the mathematical modeling, so there are different types of the sensitivity. So if this becomes more sensitive, that will become more productive. Applicability of the study data to individual patients. So basically we are combining a group of patients. So for individual patients, one drug may be cost effective or cost benefit. For another patients in the same group, that may not be cost effective or cost benefit. But ultimately we have to take the average. And also the physician factor. So some physicians have some more predilection for some drugs rather than other drugs. So in my understanding, I know that this drug is very better. Irrespective of this cost or pharmacoeconomic evaluation, I will use the drug A in spite of the drug. So it can happen. So this is all about the pharmacoeconomics. Thank you. Next program. So any questions for pharmacoeconomics है तो then main data जानता हूँ कि pharmacoeconomics concept है कि ये तो बोला था ये वो भी जानते ना cost beneficial approach and cost utility approach. এই চারটের মধ্যে মোস্ট ইম্পর্টেন্ট হচ্ছে কস্ট এফেক্টিভ এন্ড কস্ট বেনিফিট approach. এটা আমাদের খুব কাজে লাগে যখনই আমরা বিভিন্ন রকমের গ্রাফস দেব তখনই এই দুটো আমাদের কাজে লাগে. Next part will come to another conceptual thing, that is the pharmacogenomics. So again I'm telling that basically we are not using the drug based on the efficacy and safety as a blanket therapy. So যাদের ডায়াবেটিস হয়েছে আমরা জানি 5টা ড্রাগ আছে 5টা ড্রাগ আমরা দিয়ে যা যেরকম পেশেন্ট ফ্যাক্টর আছে রয়েছে, কিন্তু ইন দ্য ফিউচার মানে এখন যেটা আসছে, so we can individualize the drug according to the genetic constitution of that person. So individualization of the drug, একই drug that may cause the side effect or adverse effect in some persons, in another person adverse effect হবে না. একই ড্রাগের এফিকাসি একজনের ক্ষেত্রে অনেক বেশি আরেকজনের ক্ষেত্রে নাও হতে পারে. যদি সমস্ত কিছু আমরা ম্যাচ করি মানে এবিসিডি ম্যাচ করলাম, এজ, সেক্স, ওয়েট, হাইট সমস্ত কিছু ম্যাচ করলাম, কিন্তু দুজনের ক্ষেত্রে ড্রাগ একই রকম কাজ করে না. So this can be more concise or more precise can be done by means of the pharmacogenomic approach, and this is the future of the pharmacology. So basically physicians are prescribing one of several appropriate drugs. যেটা আমরা বলছিলাম we are sleepiness আছে কারো ক্ষেত্রে ওটা কোনো কাজই করে না. মানে একই যদি আমরা এজ ম্যাচ, সেক্স ম্যাচ, ওয়েট ম্যাচ পেশেন্ট দুজনকে দিই, একজন প্রিগাবেলের টলারেট করতে পারে না আরেকজন টলারেট করতে পারে, এবং বিফোর দ্যাট আমরা কিন্তু সেটা প্রেডিক্ট করতে পারি না. So we cannot predict. So that is the problem. So it is also difficult to predict who will be benefited from a medication, who will not respond at all, and who will experience adverse drug reaction. So that is the problem, and ultimately that leads us to different types of the limitations also. You know, more and more medical problems are creeping up to our professors because of this, because we cannot predict that the same drug can cause the adverse drug reactions in one, or the same drug cannot act at all in another person. So currently there is no singular to determine whether people will respond well, badly, or not at all to our medication. So the important thing about this is the adverse drug reaction. So adverse drug reaction is accounted for more than 2.2 million serious cases, and there are many deaths also. So it is one of the leading cause of the hospitalization and death, not only in the United States but in the all of the world also. So time and again I am saying that the different patients basically respond differently to a drug. Part of this can be calculated or can be predicted from the pharmacokinetics, pharmacodynamics approach, but not all. So they are different parts. So genetics basically can account for the 20 to 95% of this variability in drug disposition and effects. So it has been calculated that if we also consider the genetics approach, that can account for this. So numerous examples are there where the inter-individual differences may be there, and this is also important in the pharmacokinetic approach also, because the drug metabolizing enzymes may be less effective or more effective in different persons. So in those cases the same drug can be more metabolized or less metabolized, and accordingly the effect will also become different. Similarly drug transporter. So yesterday we have discussed about the different types of the cationic transporter and anionic transporter that is present in the renal tubules that secrete the drug or reabsorb that. Again, these transporters may also be genetically different in different persons. Again, the same drug cannot be secreted or reabsorbed back in the similar amount to different persons. There are inter-individual variability. So inherited determinants are always there. So without knowing all of these involved in drug response, it always becomes difficult to predict. So basically this pharmacogenomics is a science that examines these inherited variations in genes. So what are the variations in genes? So we cannot analyze all of the genes to see in the drug, but we can analyze some variability. So beforehand we can predict that these can be some variability of genetics, and this variability ultimately can translate to difference in the response of similar types of the drugs, and this can be keeping in mind. This can be keeping in mind when we are describing the drugs that dictate the drug response, so that this pharmacology coiled up DNA here. So these are the pictures of DNA. You know about the gene in your first year. So basically, they contain the genetic code. A code is made up of pairs of the bases carried on the DNA molecule, and each DNA molecule contains many genes. And the basic physical and functional unit of the identity is this gene. They contain specific sequence of the bases carry the information needed for construction and maintenance of the cycle. Now, 99.9% of our DNA is identical to everyone. The remaining 0.1% is basically mutates the difference in the drug response. So this is the details of the DNA. You know about the double helix structure, what are the bases, etc. Now coming to the genetic polymorphism. So before that I am saying that there will be 0.1% difference, and if we can detect what are the difference, slight difference of the bases of the drugs, we can already pick up some differences. And accordingly, we can also categorize whether the drugs will be beneficial for one person or not. This is known as the genetic polymorphism. These are different forms of the DNA sequence. Polymerase may be monomerase form. So they are type of genetic diversity within the population's gene range. So it is a variation in the DNA that is too common to be due merely to new mutations. There are other mutations going on. There are slight variations, but this is more than just drastic mutation. So it is too common to be due merely to a new mutation. A polymorphism must have a frequency of at least 1% in the population. That is, these changes in the DNA base is present more than 1% of the population. So if there are 100 persons, this slight change in the bases is present, for example, in 2% or 3%. If this is present, this is known as the genetic polymorphism. But if it is present less than 1%, we can take this as some new mutations or slight change. It cannot be accounted as the genetic polymorphism. So polymorphism is common in nature. It is related to biodiversity, genetic variation, and adaptation. And it usually functions to detect variety of the forms in population living in a varied environment. So polymorphism basically happens due to the weather, due to the ecosystem, due to the areas, or due to the ethnicity, etc. It results from the evolutionary processes. It is heritable and is modified by natural states. And within this polymorphism, the most important part that is mainly required for the pharmacokinetics is this SNP. That is the single nucleotide polymorphism. It is easier to pick up and it is easier to quantitate. So single nucleotide polymorphism or SNP is a small genetic change. That is slight change, the single nucleotide change or variation that can occur within a person's DNA sequence. So single nucleotide polymorphism are DNA sequence variations that occur with a single nucleotide like A, T, C or G in the genome sequence is altered. So you know there are 4 base pairs and only one if this is altered, this is known as the single genetic polymorphism. And this alteration should be present greater than 1% of the total population. Then it comes under the party of single nucleotide polymorphism. So this may happen every 100 to 300 bases, around 3 million base human genome, and obviously I have discussed it should be present more than 1%. So genes influence response to medication. Time and again I am saying, for example, hair color is different due to the genes. Normal variation of the gene determines the specific hair color such as brown or blonde. Similarly, genes can determine how a person reacts to a medication. So reaction to the medication is pharmacodynamic activity to the medication. So a genetic variation that makes the drug to stay in the body longer than normal and causes serious side effects or variation that makes the medication less effective. Again, from this slide change, the single nucleotide polymorphism, there are drugs, you can see that there are drugs that is present, that will be more metabolized or less metabolized, that will be more eliminated or less eliminated, and accordingly that may happen some therapeutic concentration in the plasma or there may be toxicity in the plasma. So scientists are basically trying to identify the record as many genetic variations as possible. So if we have make a pool of these SNPs, so ultimately we can make some guidelines. So in which which persons or in which ethnicity these drugs should not be given or should be given like that. Once the variation is identified, scientists might be able to match it up with the response to a particular medication and then develop a personalized approach to medication. So all these pharmacogenomics approach is basically for the personalized medication. So we are now going to from the one size fits all to a personalized approach. So the same drug can be given in lower amounts or in the more frequency in different individuals, and this can be done. So in the future there may be some SNP codes, so single nucleotide polymorphism. So according to this SNP code, we can there is some guidelines that these drugs should be given for this drugs should be given like this. So it can happen in the future. So again, the pharmacogenomics is the study of how an individual's genetic inheritance affects the body's response to drug. Genetic inheritance and body's response to drug. The term comes from the words pharmacology and genomics, and thus basically it is the intersection of the pharmaceutics and genetics. It combines the pharmaceutical science with knowledge of genes, proteins, and single nucleotide polymers. So it is the branch of pharmacology, again the same thing, which deals with the influence of genetic variation or drug response in patients by coordinating gene expression or single nucleotide polymorphism with the drug's efficacy of safety. So basically pharmacogenomics is the branch of pharmacology which deals with the influence of genetic variation. How this genetic variation or single nucleotide polymorphism can help in personalizing a drug dosage, drug amount, whether the drug can be used for a specific person. It is related to a new field combining pharmacology and genomics, and ultimately our aim is for an effective safe medication and dosage that will be adjusted according to the person's genetic makeup. So we can say that this pharmacogenetic approach answers the following questions, like why does a drug show beneficial results in one and the same drug are intolerable for others? So there are some answers and there are many problems that cannot be answered. So this can be answered by the pharmacogenetic approach. Why does some need more than the standard dose of the drug to be effective? So we have been seen that the same drug in the lower dose is effective in some, but the same dose cannot heal a disease in some other persons. We need a higher dose. Why does some need only half of the standard dose for effectiveness? Same thing. So we need lesser dose of the drug than the standard dose in some individuals. Why do some people get cancer and others do? This is similar for the different drugs also. So some drugs also adverse effect in some, but in some other persons they still not do some adverse effect. Why is cancer violent in one person compared to the other? Why some drugs show more compliance for one and not for the other? Compliance means the tolerability or adherence of the drug. So the person cannot continue the drug because of some problems, some adverse effects. For example, for diabetes mellitus or hypertension, we need to continue the drug for long period of the time, possibly lifetime. So if a person cannot tolerate the drug, if the person happens to stop the drug, that will not control their disease, and ultimately that will lead to detrimental effects. So this can also be cleared from the pharmacogenomics aspect. So basically, if the optimal drug therapy, so what are the exact dosage frequency, dosage should be given to the particular person to ensure maximal efficacy. Minimum dose দিয়ে maximal efficacy of the drug হবে with minimal adverse effects. মানে একটা precise এবং concise drug হবে, minimum adverse effect হবে, maximal effect হবে এবং ultimately optimal drug therapy হবে এবং optimal adherence হবে, মানে patient continue করতে পারবে। It holds the promise that the drugs might not be as per each person's genetic nature. So in example, the genetic variation is the same thing that different drug response are exposed the way these variations can be used to predict the good response, bad response, or good response in that. Now there is another term like pharmacogenetics. So pharmacogenomics and pharmacogenetics right now it can be used interchangeably, but there is slight difference. So pharmacogenomics is basically a general study of all the many differences that determine drug behavior, and pharmacogenetics is basically the study of inherent difference of variations in drug metabolism and response. So pharmacogenetics starting with the draft. So we are seeing some changes in the draft, changes in the behavior of the draft, and next we are just analyzing whether there is any single integrated polymer is present in this particular one. So basically we are analyzing findings of the product genetic approach to see whether these changes in the draft behavior is related to some genetic outcomes. But right now the distinction between these two terms is considered arbitrary, and now they are used more or less interchangeably. But just remember, pharmacogenetics starts with the genes genetic makeup, and then we are analyzing the drugs. And in pharmacogenetics, we are starting with the changes in the behavior of the drugs, and then we are analyzing the genes to see whether there is any relation or not. And pharmacogenetics is basically the total subject, and medicine is the pharmacogenetics. So why there is a difference in sequence of the genes, that is the genetic variation and polymorphism. In that case, we can until now, sir, there are some single nucleotide polymorphisms we can identify. And the more years are going, we can identify more and more single nucleotide polymorphisms. And according to the single nucleotide polymorphism, there are list of the drugs. So we can see if this SNP is present or not, and accordingly this drug is whether it is beneficial or not, whether the drug should be given with lesser dose or not, whether with a more dose or not. So the difference in sequence of the genes was difference in enzymatic activity, which was the difference in drug metabolism, and because of this reason, we would respond same drug differently. For example, you have already read about the cytochrome P450 enzymes in the metabolism. So there are some persons who are the cytochrome P450 enzymes of a particular subtype. For example, disease may be lesser effective, or in other person they are more effective. So those drugs which are metabolized by the cytochrome P450 enzymes may be more or less metabolized, and accordingly their effects may be enhanced or decreased. So the important example of drug and dosage therapeutics, now it is used in case of the leukemia. In case of the different types of the cancer therapeutics, now the SNP is quite used. Gene variation and prediction of the drug response, the same thing we have discussed. So we have to examine the nucleotide polymorphism. But the problem is the traditional jumps technology is very slow and expensive, obviously. So it will take time to come out with more and more single nucleotide polymorphisms and more and more of the drugs that can be affected by this. And this single nucleotide polymorphism is basically picked up by a case which is known as the DNA microarray technique. So by means of the DNA microarray technique, you can pick up this is an evolving technology, pick up these changes in one base single nucleotide polymorphism. If we are just running this to the whole of genetic basis. So presence of the specific SNPs quickly and accurately can be done by the DNA microarray technique, but it is also very much costly. So integrated drug disposal, already we have discussed whether it is drug metabolism or drug absorption or drug elimination. All these are done by means of different types of the cytochrome protein or transporter protein or different types of the enzymes. So all these are basically synthesized from the DNA. All these are basically coded by the genes, and these genes contain the codes that codes can be changed more than 1% polymorphism. So single nucleotide polymorphism can happen. So ultimately the drug behavior can be different. Drug metabolism already we have discussed the example like cytochrome P450 enzymes. So there will be different drugs, and actually the cytochrome enzymes, the drug metabolizing enzymes. So enzyme is the protein, and protein is coded by the DNA, again the same thing. There will be changes in the cytochrome P450 enzyme level in different persons. So we can just pick up these findings of the single nucleotide polymorphism. So there will be some persons where the cytochrome P450 enzyme is very less effective. So here we have to give the lesser amount of the drug. So otherwise, because the metabolism is lesser, there will be more toxicity. This is a different example like cytochrome P3A5 deficiency. There are different drugs that can be utilized. Drug transporter, one is discussed. So not only the metabolizer, different types of drug transporters are there. Be in the initiation phase, be in the different drug disposition phase. And these drug transporters are also proteins, and these can also be coded by the different types of genes, like E-glycoprotein, ABCD1 gene. In the previous class, I have discussed about the E-glycoprotein. It's benefits of the pharmacogenomics. So it is clear if we are considering the pharmacogenomics, we can come up with a more powerful medicines. So more medicines that is most effective in one person that may not be effective in another person. The adverse effect will be very less in that person. That adverse effect will be more in another person. So that can be personalized and it can be more efficacious, more safe as well. Rejection of the trial and error therapy. Basically, we are giving a drug. If the drug does not function, we are changing the drug. And ultimately, that will cost the time. So again, the humanistic outcome, the quality of life may be compromised. So beforehand, if we can know the SNPs, if we can know that this drug is not beneficial to this person, drug A is not beneficial for this person, but drug B can. So we can start with the drug B, not with the drug. But already we have discussed findings of the clinical trials, meta-analysis, pharmacoeconomic approach. The guidelines have given one drug as the first line drug. So this is a one size fits all approach, but does not function that way for all the individuals. So if the appropriate dosage, what are the appropriate dosage that should be given one person? That can be specialized screening of the diseases. So screening of the diseases can also be done by the SNPs. So SNPs is there, so there could be more predilation for some diseases. So accordingly, we can also adopt some preventive approach also. There are different types of the drugs or different types of the vaccines that can be given to prevent the drug. So this can also be employed. Better vaccines already have discussed. So better vaccines can be given, and vaccines also not for all. So those persons that are more predisposed for something. Is your drug discovered? So if we know that here is the problem, so this drug can be tested to whether that can be beneficial in those problems or not, instead of just the blanket drug. Reduction in healthcare costs. So ultimately all this translates to pharmacoeconomic approach. So until now the pharmacogenomics approach is quite costly, but in the future it may be some that if we are coming out with a catalog of the single nucleotide polymorphisms, we have a catalog of the drugs that will be effective for different ethnicity, different individuals. So ultimately pharmacoeconomically that will be a very beneficial. In the first part we have discussed about the cost effectiveness approach or cost beneficial approach. So it can be seen that if we employ the pharmacogenomics in the future, it will be also pharmacoeconomically more viable. So of course there is barriers because the pharmacogenomics is still in its infancy and we have limited knowledge about the genes until now, but in the future we can hope that it must be change. So application of the pharmacogenomics until now to help in prediction of the exact growth of a particular drug to a particular patient. Most important application is to target parameter subset of disease to test viral genome such as selective treatment for HIV resistance. Basically, it is now used in different types of the cancer therapeutics or different types of the intractable diseases, intractable malignancy or intractable infections like HIV. To effectively create clinical drugs, researchers are also using the genetic test for variation in P450 to screen and measure disease. So in the recently when they are coming out with the newer drugs, they are also testing already we know some variations, some SNPs of the cytochrome P450 different subtypes, and when a drug comes, they are also just testing these two different subtypes of the cytochrome P450 individuals to see whether the new drug will become more effective or less effective in different subtypes. So conclusion, it is an alternative for better clinical diagnosis, fewer clinical failures, faster drug development, and the motto is of course to reduce the rate hospitalization due to adverse drug reactions. So thank you. Thank you all. So any questions on the pharmacoeconomics and pharmacogenomics? So in the pharmacogenomics part, you have to know what is pharmacogenomics and also pharmacogenetics and how this pharmacogenomics can be used in our armamentarium, that is in the pharmaceutical treatment of the drug. So these are the areas, that is what is single nucleotide polymorphism, how we can capture and how the changes in the drug metabolically enzymes or drug transition proteins are changed according to the genetic polymorphisms and how it can be employed for a better treatment outcome or better efficacy with minimal adverse effects with optimal
So what we learned today is a general parameter, basics of parameter. Microbiology consists of basically three subjects. One is general microbiology, virology, and parasitology. Okay. So we will learn the basics of parasitology. It is a very short and basic. What is learning objective? The life cycle of parasites basic. Laboratory diagnosis and treatment of parasites. Now, what is parasite? Parasite is a kind of living organism which lives in our body upon another organ, like food, and derive nutrition directly from it without needing any benefit from the host. Just an example. Like our calculator, boyfriend, feedback for a and it is medical parasite, animal parasite, which infects and produce disease in the human. Now there is a lot of parasites. That is medically important. Those can actually causes disease. Okay. And parasites may be classified as ectoparasites and endoparasites. And what is ectoparasite? That inhibit the surface of the body of the host without taking the tissues. অনেকের বাড়িতে ডগ পেটস আছে, রাইট? পেটসের বাড়িতে দেখতে অনেক সময় অনেক রকম ফ্লিক্স পাওয়া যায়, হ্যাঁ? This is kind of parasite examples of ectoparasites. যারা বাইরে থাকে, ওরা একটা living outside. Serve as important method of transmitting the pathogen of microbe. Infection produced by these parasites are infectious. What is endoparasite? Endoparasites are that are living in the body of the host. I mean, they are body representation. Everyone knows Bengali or infection by the endoparasite is called infection. Okay. Now, endoparasites are further classified into the protozoite. So there are two types of parasites. One is ectoparasite or living outside, and one is endoparasite, so living inside. And now endoparasites are classified into one is protozoa and another is cell. And we have to know some medically important protozoa and studies. What is the medical important protozoa? Amoeba. What about amoeba, right? Infections, Entamoeba histolytica, amoeba, then Ingrata, Acrophyta, these are all the examples. Flagellates, intestinal flagellates, or Giardia, Diarrhea, genital flagellates, Trichomonas, hemoflagellates, Dystonia, Trichomonas. We will study later in detail. So, সবার পরে এখন শুধু একটা ফিক্সড ক্লাস ব্লক ঠিক আছে পরে আস্তে আস্তে malaria parasites and parasites we all know about malaria opportunistic toxicant parasites toxoplasma Cryptosporidium, Cyclosporus, Microicepora, these are the opportunistic. What is meaning of the opportunistic? Immunity suppressor. Now HIV patient, long time bone marrow transplant patient, there is no need to that. In that process, this protozoa infection the miscellaneous protozoa balance. Medically important health. And health things are classified into four categories. Cysto, somatic nematode. Now what is cyst stone? Cyst stones are diphtheria, pneumonia, echinococcus, nematodes are Fusarium, Pseudomonas, Fasciola, intestinal infection, typhus, caterpillar, worm, and last the somatic silent. Now the life cycle of that. So depends upon the three factors: host, mode of transmission, and the infective form. So basically, if I go to the each and every parasite life cycle, every life cycle is more or less same, right? They come into the feces, larval stage, gestation is the mouth, they hatch into a lung or any organ, and after that they adapt. So this is the kind of thing, but you have to know each and every life cycle. What are the different things? So organisms which harvest the parasite provide the different ancestors. That is what food can be classified into when the parasite undergo sexual cycle or intermediate when the parasite undergo asexual cycle. And life cycle of the parasite is dynamic. Life cycle, parasite differs only one host to complete the development. And indirect cycle, parasite differs for that three hosts, one repeating host and another or intermediate host to complete the development. Now, what is infection? In your fiber, you will be asked what is the infective form of that disease. So morphological forms of the parasite is transmitted to man. That is what actually infective form. Now that is a term called open. Now what is open? These intestinal parasites may infect the same person by contaminated hands, internal organs, or by reverse reciprocity. Now what is reverse reciprocity? Reciprocity is movement of our layer system. There is constantly compaction and हमारे thought में action in directional movement but हमारे direction का change हो जाता है. That is called reverse reciprocity. Okay. So second internal organization. External organization মানে हमारी nervous और जो हाथे की contraction সেটা আমরা নিয়ে সেটা আবার ম্যাচ করব Now the life cycle of various molecular parasites. So this is a kind of chart when you completed the parasite part. This chart will help you in fiber because these things are actually asked in fiber. What is the second form of this? What is the actually technique? What is the technique? This is a very important slide. Just now look at it. But when you complicate the whole parasite, they will be ready. Let us speak it. Now the laboratory activities of parasites. How we diagnose parasites? As many parasites and many the intestinal tract, so stool examination is the most common diagnostic technique used for the diagnosis of parasites. Right? Now specimen of the collection. Two specimens should be collected in white form. Three cap container. And here to be avoid that one is the form of collected before the starting on the experiment because if we start the drug, right, we can't get the worm or internal organism in the frequency. At least these two specimens are collected on alternately within 10 days, except intestinal analysis is recommended. Now, when to examine, liquid stool specimen examines within 30 minutes because track. Second one is within 1 hour and forms after 24 hours after collection. For monitoring the response of the therapy, it is to examine after the therapy what is the usual event. Suppose someone has an infection, if we start using anti-parasitic drug, then we have to set the disease to confirm in that what parasite is gone. 5. If delay in transport, because transport sometimes is not possible to set the specimen within 1 hour or within half an hour. Because the thing is that these are waiting for the occupancy of the parasite for the specimen other than this, actually we are using it in children, variant of swab or what is called inhaled swab. So we just attach the swab in the buttock of the children and then we collect it and examine. Urinal content sometimes rises to aspiration. Now, what is the activity? Now, macroscopic activity. Macroscopic, what we actually do in naked eye. Active activity simply you can suspect different activity. What it does, what it is, validity. Because recently has lots of differential diagnoses. It can be by singular, it can be by subcellular, it can be by complementary. But if you suspect the parasite, okay, these are the main differential diagnoses. Color, dark red stool, apart infection, a bright red stool is a bleeding for lower GI. For the offensive containing fat counting here. Now stool count. This is the one of the important strategies regarding stool count. In liquid stool, crocodiles are usually found and semi-formed stool, both crocodile sister. In formed stool, sister is found. Next, microscopic includes direct weight computation and permanent medicine. In routine practice, we will just go for the weight mount to this is an example of dynamic weight mount. Blocks of saline and full saline for the contrast are placed on left and right half of the slide. Small amount of pieces in the form of substance. And how we look into the microscope because of the meaning of the slides. In an exact direction, forward placed on a mount and examine under the path and low ground forward meanings for a detection of the disease and larva, followed by high count. For this, you should not look this by 100. But you have to when we focus on any kind of on any kind of age or right, you have to keep in your practice this thing. So first you have to find out by a tennis, okay, and after that for this. These are the examples of various aims and proposals. Select useful indication of observation and use of monomer and eggs and larva of eggs. Advertisement and hiding function. Motility of monomers and larva biospheric property anti-activated, biospheric is anti-activated and non-biospheric is anti-activated. And hiding function. Why sometimes we need dual sided? Why? That the nuclear details of the protein and larva are better visualized. Some of eggs are actually biological or compared to the right one. And the parasite of the larva intermediate, uniform, and nana. This is one of the most important type of questions. What is the non-binding? What is the binding? These are the commonly asked in parasitical fiber. Okay, what you have seen from this type of morphology, there the immediate host, definitive host, and in some biostates and non-biostates. Parasite is like very decoding of the waveform decode is immediately and result is decoded as result is identification and only after examination of permanent states in a and how can you permanent states? This is not maximum because these kind of setup is not available many times. Required actually detection of protozoal states. Proposed by changing their internal structure, commonly used for iron protein state, primary state, modified acid percentage. Yeah, modified acid percentage. You can prepare a sample of immunocompromised, right? Infection by sustained. In that case, we do a modified acid percentage. Concentration. Sometimes might see a very low amount of things, so you can't find it including that. You have to do a proper concentration. Okay. So the basket output is very low, and the right is not able to get the parasite. Need to be concentrated. These methods are also used and also the activity eggs and the larva are informed of the process, but the protozoa get commonly used concentration that also will take a separate class when we do practical balance. These are the common things: gelification technique, rotation technique, desalvation rotation technique, and the solar rotation. This is another important slide for your hyperparticle because when commonly we ask how to run the concentration techniques in some concentration. So what will I go to the last meeting? Actually, if you just recapitulate before your diagram, then go to the slides. Actually, you can simply complete your diagram. So morphological forms of parasites protozoites in intermediate like adult form asterisk and everybody adult form eggs of larva of egg counting. How is counting egg quantity? Direct counting because cartograph sticks in method and scopes method or examination of blood. Usually diagnosis of examination of blood. Usually diagnosis of blood pressure, right? Plasmodium, like malaria, trypophoma, leukemia, malaria, leukemia, and various methods of the examination of blood, direct examination of blood, quantitative blood report, and concentration of blood. So, some microscopic examinations of peripheral, leaf form, plasmodium, malaria is very important, right? You will get a definite question from malaria. You have to make each and every in the medicine part in micro. We have to malaria very. So now in your time. These are the micro blood. and also the CSS and UAP can form various subgroups. The paradigm, take of paradigm. Generally, we find paradigm here. Norms during the aspect of immunotype. Detection of the parasite antibodies in serum and detection of circulating parasites in serum. This because the parasites are detected only during the early stage of disease, right? By parasites often in small numbers. Parasites reside in internal organs and molecular identification is not possible. In other techniques like culture or microscopy. So, just like serology, like malaria, we have done KCP, right? Including MBBS. This is a kind of example of alternative method of action. Antibodies are releasing various parasites from serum, germline, from the CSA, or blood. And what are the kind of examples? Animal liver disease, ELISA, detection of antibody, sponsoring functional detecting antibodies to artifact some saline treatment and product. We have discussed malaria. Now, apart from apart from blood direct microscopic assay, apart from antivenom antibody assay, some tests like molecular system is here, and biomass is also modified for multiple PCR. We had complicated multiple PCR. The actual and there we can detect more parasites. Thank you. These are all.